what you can do in health systems, there are issues that are micro at the level of the individual provider, the individual, and we've been focusing a lot on that today. There's more meso ones in terms of how organizations are set up. And I'm going to focus more on the macro level, the view from 20,000 feet and how some of the ways in which the system is set up can or can't get in the way. This is my cartoon on health reform. On the left is where we are now. On the right is where we would like to be. The middle part reads, then a miracle occurs. And the critic is saying, I think you should be more explicit here in step 2. So my necessary disclaimer, and I am repeating also what Dr. Newbold indicated, is that we're talking about health care here, and it leaves out a lot of the very key factors that influence how healthy people are. Housing, food, air quality, water quality, all kinds of things are absolutely critical. Also to note that the issues around immigrant health are not new. I was born and grew up in Toronto, and I remember when I was a child and you would hear that somebody was in the hospital, you would not ask what hospital, you would ask what room, because there was only one hospital that if you were Jewish, you could get kosher food. So by definition, any Jew would go to that one hospital, although occasionally if they couldn't, they go to the Seventh-day Adventist because you could get vegetarian food. But so what's the Canadian system? That's a trick question. There is no such thing as a Canadian system because constitutionally, we gave health care to the provinces and it's a provincial responsibility. So there's an enormous variability both between provinces and also within provinces. One size doesn't fit all, and you were hearing some of that just in terms of the question about how well you could get care if you were in a rural remote area as opposed to if you happen to be in an area nearer some of the facilities. The difficulty in trying to use telehealth because of that if you're licensed in one province, you can't necessarily practice in another province. So that, you know, to set the thing up, we've got all of these provincial rules in place. Also, if you talk to Americans, you can tell them, no, we don't have socialized medicine. We, in fact, don't have an NHS model. What we have is public financing of certain types of health services, and they're provided by private providers. A lot of them are not for profit, but it's confusing when you talk about a public hospital. Public hospitals are not public, they are private, not for profit. Doctors are not civil servants, they are private providers. So whenever people say, oh, we need to have more role for the private sector in providing health care, it's, guys, it's almost entirely private now. And then to totally confuse the Americans, we call it Medicare, which is what they call their system of care for people who are elderly, but it's actually was set up as basically a very similar model. So what about private money? Private money can come from private insurance, which is also employer provided. It can come from out-of-pocket payments, it can come from charity. And even though people talk a lot about how public the Canadian system is, we're on the low end internationally. We're about 70% public financing. Now, you can get into stupid nuances around what you count and what you don't count, but for the most part, we're on the low end in terms of how much is paid for publicly. What's the role of the federal government in this system? It's to send money. And the money goes into provincial general revenue. So we have lots of battles about how much and how you distribute it, and what strings are attached, and I won't get into the details here. And right now, provinces have to comply, and Dr. Lowy mentioned the Canada Health Act. They have to comply with the terms of the Canada Health Act, or some money is withheld. But the Canada Health Act, as you will see, does not by any way, shape, or form cover everything we do. Now, it's one of the things, this change in funding formula made things easier, because in the old days, you would only get federal money if care was given by a doctor. So if you had a nurse practitioner project, you couldn't get money if the care was given by the nurse. So fortunately, after '77, that changed. But the Canada Health Act is this piece of federal legislation, and it's a floor, not a ceiling. It's based on 2 old pieces of legislation. And it says, look, if you're a provincial territorial plan, You have to cover all medically necessary care for all insured persons, and that gets into who counts as an insured person, and there's definitely issues around immigrants and refugees about when you qualify. If you move from one province to another, you're not an insured person in that province for 3 months until you've settled there. If you're a foreign student, you're not insured. So you get all kinds of little things around who counts as an insured person. But there's no co-payments for insured services, but the insured service definition is based on old law. So it's based on where care is delivered, which is in hospital, because there was an old Hospital Insurance and Diagnostic Services Act, or who gives it, which is by physicians, because there was the Medical Care Act. There's nothing stopping provinces and territories from going beyond it, but they don't have to go beyond it. And you'll see that's where the big differences are. So the hospital service definition was incredibly expansive. Anything to inpatients or outpatients at a hospital if it's medically necessary to maintain health, prevent disease, or diagnose or treat an injury, illness, or disability. And it includes the accommodation and meals, and they can't zing you if you're in a private room because you're infectious, so they can zing you if otherwise. Nursing, labs, radiology, and you see again, you can see lawyers writing this. Not just the lab test, but interpreting the lab test. So they can't say, well, we'll pay for the lab test, but if you want to know what it means, that'll be open up your wallet, please. The drugs, the biology, in the hospital. So and that's again why some of the numbers get tricky, because pharmaceuticals are in the hospital line when they're in the hospital. So your pharmaceutical line on the CIHI numbers only are the outpatient pharmaceuticals, they're not the inpatient pharmaceuticals. So some of that just moves. The operating room, the case room, the medical surgical equipment supplies, the radiotherapy, physiotherapy, anything the hospital's doing. And you can see when I said 70% public funding, it depends a lot on what. Hospitals, 99%, physicians, 99%. The other fee-for-service professionals, 7%. The drugs, about just over a third, but again, that's a complicated thing, what you want. So what I call the first law of cost containment is that the easiest way to contain costs is to shift them to somebody else. So if you move care out of hospitals, you move it out of the rules. It's no longer under the Canada Health Act rules. You don't have to pay for them. A lot of them are clearly medically necessary. Prescription drugs for cancer treatment. You keep seeing the sob story of the week of the person not getting their prescription drugs paid for because they're an outpatient. But also a whole lot of the things that we've been talking about today. Outpatient drugs, rehab, long-term care, home care, mental health. Because mental health was excluded from the old law because when they put the law together, they assumed mental health meant provincial psychiatric hospitals. So since provincial psychiatric hospitals were already being paid for by the province, you didn't need to include them, so they excluded mental health unless it was less than 10% of the hospital beds. Mental health sort of fell through the cracks on this because it was done differently. So it depends on where you're giving the care. If you're in a hospital emergency room, it's going to be handled differently than if you're a private clinic. If it's given by a doctor, it may be different than if it's by a nurse. May depend on patient and disease. You may have special plans for seniors, special plans for those with cancer, special plans for those with HIV/AIDS. So one of the problems is that people then say, oh, we need more money to the hospitals, we need more money to the hospitals, because you're going to get it if it's in the hospital, even though other ways may be much more cost-effective and make a lot more sense. And Dr. Bowman's point about the workforce comes in here clearly, because a lot of this new workforce is being delivered in places other than the hospitals. Now, another point I want to make is that health costs are often large and unpredictable. That's why we need insurance. And they vary across the population. So we, years ago, did some research where we looked at the distribution of health expenditures. This started when Alberta was saying, oh, we should go to medical savings accounts, and the, Kirby report was saying we should be thinking about medical savings accounts, and there was a whole big push for medical savings accounts. And we said, what's the data show? So Manitoba is a national treasure, and Manitoba allowed us to take their data for doctors, hospitals, and physician drugs. We arranged them in vintiles, which is 5 percentile groups, arranged them from the lowest to the highest spending to look at the distribution. And I'm double counting, I'm showing the top 1% here. And this is what the distribution looks like. And you can see that, yes, on average, you were talking $2,200 per head, but you don't hit that to the 80th percentile, and a phenomenal amount of that money is the top 1%. And I'm crediting the people who helped me out in this in Manitoba, because they're phenomenal. And there's actually a piece on SSRN from one of my PhD students, Ken Lamb, which has some of the numbers. One of the key things to realize, and Dr. Sinha noted that, is that age-sex adjustment isn't enough to do it, because in every single age-sex group, 80 to 90% of people are less than the mean for that group. I mean, and one of the reasons why it looks high in the seniors, can you guess how come it looks like it's so much higher in the oldest age group? You're picking up end-of-life care. So if I die at 55 and I incur costs, or if I die at 85 and I incur costs, the issue is not that I've incurred the costs, the issue is what happens in those 30 years. And a whole lot of these numbers that are scaring the heck out of us as, oh, look what we boomers are going to do to health costs, are bogus. Because what it's just doing is picking up that eventually everybody dies, so that on average you're picking up those end-of-life costs in that. And that, when you actually look at the contribution of aging to health expenditures, it is way less. And Dr. Sinha did notice that in his thing. But what it does mean is, if I go to competitive models for insurance, I've got a problem, because if I'm a smart insurer, who am I going to rather write policies for? And if I can figure out how to avoid that top 1 to 5%, look at how much money I'm going to make, because I'm taking a big chunk of the population and I'm not having to pay for their care. So that's the big problem that we're running into in the U.S. and the Affordable Care Act and all the pre-existing conditions. Okay. So the accessibility issues, they include how do we get timely action to quality services, and that's the access, and that's the whole waiting time. The financial barriers to care that escape from the comprehensiveness definition: home care, pharma, transportation. If I'm going to regionalize services, how do I get there? Non-financial barriers. Dr. Moonwell gave a beautiful example, but there was also a really neat one in Manitoba. They were trying to figure out how come poor women with second and subsequent kids weren't getting prenatal care, which didn't make a lot of sense because it's an insured service, and they found out that they couldn't figure out how to get to the doctor's appointment without child care for the first child. So they weren't going for care because they didn't know, they couldn't handle the transportation and they couldn't handle the child care. So this is not a health issue, but it certainly affected their ability to get prenatal care. The issues around what constitutes reasonable compensation for health workers, and again, Dr. Bowman raising some of those. The big problem that we run into is that there's the question about who should be paying for what. What's society's responsibility? What about voluntary organization, including faith-based groups? What about individuals and their families? And that's nothing to do with evidence. That's values. And one of the things that worries me a lot in the current debate is we have redefined equity as leveling down. So if you've got something and I don't have it, instead of saying I should have it too, it's take it away from you and then we're equal. This is great. So we're getting this whole leveling down of benefits under the rhetoric of equity and how unfair it is that some people have stuff that other people don't. Also, you have to, it's also values, but certain things are just penny wise and pound foolish. If you have an outbreak of tuberculosis because you haven't treated it, this is not exactly a cost saver. If somebody has a stroke because their blood pressure isn't under control, or a kid needs to be hospitalized because the asthma is not under control, it's not exactly cost saving to have that happen. So it's, again, one of the things that we should be looking at. And my policy assumption in all policy things is there's no quick fix, because the tough policy questions are often about trade-offs. And a US political scientist named Aaron Wildofsky used to say, when you have a complex policy issue, you don't solve it. What you do is you replace one set of problems with a new set of problems. And if you're successful, you like the new problems better than the old ones. Thank you.